MSK, Anatomy and Physiology, upper extremity nerves. All right, so before we get started, this is our MSK, our musculoskeletal section. We're going to be splitting it up between MSK, one section, and then rheum as another section, and then derm as a third section. Okay. Luckily for you, MSK isn't the highest yield of things. Along with derm, I would say rheum is probably more high yield compared to the other two. So just keep that in the back of your mind as we go through this. So first off, we have axillary. Let's just start off. This is the upper extremity nerves, okay? And these are the key nerves that play a role kind of in the hand and the arm. So first we have our axillary nerve. What they want you to know about the axillary nerve is that it can be injured due to anterior dislocation of the humerus. Also, it's injured in the fractured surgical neck of the humerus, okay? So those are the two areas in which you will have an injury to the axillary nerve. Surgical neck of the humerus and anterior dislocation of the humerus. Okay. Now, the presentation of the patient is going to have a flattened deltoid because the axillary nerve is going to provide innervation to the deltoid muscle. So without axillary nerve, you're going to have a flattened or atrophied deltoid muscle. So you also have the loss of the arm abduction at the shoulder greater than 15 degrees, and we'll talk about why that is the case later on. And then loss of sensation over the deltoid and lateral arm. Okay, it's very straightforward. That's the presentation of the axillary. What you should take away from this is that there's two causes. They want you to know the causes. Fracture of the surgical neck of the humerus, and then the anterior dislocation of the humerus. Those are two important things. Next high yield one is going to be the radial nerve. Radial nerve is going to be caused, the causes of injury of radial nerve is going to be compression of the axilla. So a patient can use crutches over a long time, or they sleep on their arm over a chair, and this is known as Saturday night palsy. The reason it's called Saturday night palsy is because kids that come home, they're hammered, they drink too much, and they fall asleep on their arm. Well, they can't wake up. They don't wake up because they're knocked out. They're blacked out. So they don't wake up from the tingling sensation of the nerve essentially becoming ischemic. So that when they finally wake up and they're no longer blacked out, no longer drunk, they realize that they have Saturday night palsy, which is just radial injury because of sleeping on it. Another cause of radial injury that they think is very high yield is mid-shaft fracture of the humerus. So if you have a mid-shaft fracture of the humerus, it's going to be radial involvement, okay? And also, another association with a mid-shaft fracture of the humerus is not only you'll have radial nerve involvement, but you'll also have deep brachial artery damage. And it's important to know that the radial nerve and the deep brachial artery are going to travel somewhat near each other when you're at the kind of the mid-shaft of the humerus. So that's why the mid-shaft fracture of the humerus is going to lead to both the radial nerve damage and deep brachial artery damage. Now, what's the presenting symptoms going to be like? Well, you're going to have wrist drop, okay? So you can no longer have extension of your hand, okay? Very straightforward, really easy. Wrist drop is the key thing to know about radial nerve damage, all right? Next is going to be median nerve damage. Median nerve damage is going to be usually due to supracondylar fracture of the humerus. So I don't know if you've noticed, from axillary to radial to median, we've gone from proximal to distal on the humerus. So proximal fractures are going to be axillary involvement, middle fractures are going to be radial involvement, and then distal fractures of the humerus are going to be median involvement. So supracondylar fracture of the humerus. And the way that they remember that is ARM. So ARM, axillary, radial, median. So from proximal to distal fractures of the humerus, those are going to be your associated nerve damage. And it's very high yield to know that. It's so helpful to know that. Probably one of the most helpful things in MSK. All right. Now, another high yield association with median nerve is carpal tunnel syndrome. So carpal tunnel syndrome can cause the compression of the median nerve. And so that's why you will see the deficits that you do in carpal tunnel syndrome. And we'll talk about that pathology later on. Now, when you have damage to the median nerve, you're going to have the hand of benediction or ape hand. This will also present with loss of flexion, wrist flexion. Okay, you have loss of wrist flexion. You could also get loss of sensation over the thenar eminence, and that's going to be an association with carpal tunnel syndrome. Okay, and we'll talk about those later on. But remember, the hand of benediction is kind of higher yield for the median, and you know that, right? Because the median nerve is going to supply essentially your pinky and your pinky to your middle finger, right? And so that's why you have the ape hand or the hand of benediction, because of the loss of those three fingers. Okay, the ulnar nerve. Not too much to focus on here. I think the main takeaway here is its fractured hook of hamate from fall on outstretched hands is going to be high yield association from this. And then compression of the nerve against the hamate as the wrist rests on a handlebar during cycling or things like that. That's where the ulnar nerve can get damaged. And we'll discuss those later on, right? This is just for your knowledge of the upper extremity nerves. And what you're going to see as a deficit is the ulnar claw. Okay, so take a look at what the ulnar claw looks like. It's relatively similar to the hand of benediction, just a little bit of differences. And so overall, what I want you to take away from this is, first off, the humerus fractures. So from proximal to distal, you will have arm, axillary first affected proximally, then radial, then median, most distally, okay? Now, number 2, there's some odd thing that I kind of want to bring up here. The anatomical neck fractures, so whenever you see an anatomical neck fracture of the humerus, you can get humeral head necrosis. And you know that, you understand that, because you're going to knock out the artery that supplies the humeral head. So be careful when we have an anatomical neck fracture. It could lead to necrosis of the humeral head. Another thing that they like to ask you on is hyperextension of the elbow, usually like secondary to fall on outstretched hands. That can cause a supracondylar fracture, supracondylar humerus fracture. And we already discussed this, right? So on the median nerve, whenever you fall on outstretched hands, you can have a supracondylar fracture of the humerus. So you get median nerve damage, okay? But what they want you to also know is that the brachial artery is going to potentially be damaged as well. All right, so keep that in the back of your mind. The median nerve with the brachial artery can be damaged in the supracondylar fracture of the humerus. For the radial nerve, remember that for mid-humerus fractures, it could be the radial nerve and the deep brachial artery damage, okay? So just remember those kind of nerves and arteries running together. Those are the 2 high-yield ones, all right? Next, we're going to be discussing the rotator cuff muscles in the next chapter.